about the process of labor and birth. So, attitude. So, attitude refers to the relationship of the fetal body parts to one another. So, a fetus's normal intrauterine attitude is flexion. So, the fetal back is rounded, the head is forward on the chest, and the arms and the legs are folded in against the body. Station. Station is the measurement of the progress of descent in centimeters above or below the midplane from the presenting part of the ischial spine. So definitely know your stations and how to identify which station the fetus is in. So station 0 is at the ischial spine. Minus station is above the ischial spine. Plus station is below the ischial spine. Engagement refers to when the widest diameter of the presenting part has passed the inlet. This corresponds to a 0 station. So know your 0 station is at the ischial spine, your minus station is above, your plus station is below, and it's measured in centimeters. All right, we have true labor versus false labor. So true labor is when your contractions are regular, they become stronger, they last longer, they occur closer together. You see that progression of contractions. You're also going to have cervical dilation and effacement, and then the fetus is going to become engaged in the pelvis and begins to descend. Whereas with false labor is not going to produce dilation, effacement, or descent, and the contractions are going to be irregular without that progression. Also, with false labor, activity such as walking usually relieves the false labor, whereas it would not relieve true labor. All right, so fetal monitoring. Certainly know your normal fetal heart rate, which is 110 to 160 beats per minute. You have external fetal monitoring and then internal fetal monitoring. Internal fetal monitoring does include rupturing the membranes and attaching an electrode to the presenting part of the fetus. The patient must be dilated 2 to 3 centimeters in order to perform internal fetal monitoring. Now, we know our regular heart rate is 110 to 160. So fetal bradycardia is a fetal heart rate of less than 110 for 10 minutes or longer. And then the fetal tachycardia is a heart rate of greater than 160 for 10 minutes or longer. If fetal bradycardia or tachycardia occurs, you need to notify the physician as soon as possible, try to change the position of the mother, administer oxygen, and then assess the mother's vital signs as well. All right, so accelerations. Accelerations are usually reassuring, so they reflect a very responsive, healthy baby. So it's temporary increases in the fetal heart rate of at least 15 beats per minute more than baseline, lasting at least 15 seconds. They normally occur with fetal movement. They may be periodic and occur with contractions, or they may be non-periodic and have no relation to contractions. Now, early decelerations, these are decreases in the fetal heart rate below baseline. So the rate at the lowest point of the deceleration usually remains greater than 100. They occur during contractions as the fetal head is pressed against the mother's pelvis or other soft tissues, and then after the contraction, the fetal heart rate will return to normal. So early decelerations are not associated with fetal compromise, and they require no intervention. So when you're looking at the early decelerations on a test strip, early decelerations are going to have a uniform shape, and they're going to have a mirror image. They're going to mirror uterine contractions. As opposed to late decelerations, which the pattern with late decelerations, it looks similar to that of early decelerations, but it begins after the contraction begins, and it returns to baseline after the contraction ends. So late decelerations are non-reassuring patterns that reflect impaired placental exchange or uteral placental insufficiency. So interventions are going to include immediately improving placental blood flow and fetal fetal oxygenation, you're also going to want to notify the provider. With variable decelerations, these are caused by umbilical cord compression. So variable decelerations are significant when the fetal heart rate repeatedly declines less than 70 beats per minute and persists at that level for at least 60 seconds before returning to baseline. If you notice variable decelerations, you want to discontinue oxytocin if it is infusing. You want to change the position of the mother, administer oxygen. You're going to assess the mother's vital signs and notify the primary care provider or notify the physician or obstetrician. Also, you may assist with an amnio infusion if it is prescribed. So an amnio perfusion is the intrauterine installation of warm water that helps to decrease compression on the umbilical cord. All right, so there are 4 stages of labor. So stage 1, this is where you have effacement and dilation of the cervix. The mother is usually very talkative and eager in the latent phase, and then she becomes more tired and restless as the contractions become stronger and more frequent. If membranes have ruptured, you want to assess the fetal heart rate because of the risk of prolapsed umbilical cord, and you're going to want to assess the color of amniotic fluid because meconium-stained fluid can indicate fetal distress. All right, stage 2 of labor. So the mother is going to have an intense concentration on pushing at this point. She's going to feel that urge to push called the Ferguson reflex. She also may fall asleep between contractions. So stage 2 involves actual expulsion of the uterus. Stage 3 is separation and expulsion of the placenta. This normally occurs anywhere from 5 to 30 minutes after birth. You have the Schultz mechanism, which is where the center portion of the placenta is expelled first. It's a shiny surface. Or the Duncan mechanism is where the margins of the placenta separates and then the dull red rough material emerges first. Stage 4 is 1 to 4 hours after birth. So it's when the mother's blood pressure and heart rate return to a pre-labor level. You also want to monitor the lochia discharge. The lochia may be moderate in amount and red in color. The lochia is the vaginal discharge after labor. It usually lasts for about 3 days. All right, so the Bishop score. The Bishop score is used to determine the maternal readiness for labor, and it evaluates cervical status and fetal position. It's indicated before the induction of labor. So there are 5 factors of the Bishop score. Each are assigned a score 0 to 3, and then you have a total score that is calculated. So those 5 factors include dilation of the cervix, effacement of the cervix, consistency of the cervix, position of the cervix, and station of the presenting part. So a score of 8 or greater indicates a good chance for a successful vaginal delivery and that the cervix is favorable for induction. All right, oxytocin. It's very important to remember that for oxytocin, an oxytocin infusion is discontinued if uterine contraction frequency is less than 2 minutes or contraction duration is longer than 90 seconds or if fetal distress is noted. So know when to discontinue an oxytocin infusion. All right, an amniotomy is artificial rupture of the membranes to stimulate labor. So this is performed if the fetus is at station 0 or a positive station below the ischial spine. It allows for increased efficiency of contractions. However, with an amniotomy, there is an increased risk of prolapse cord and infection. So whenever you have that rupture of membrane, you really want to assess that membranous fluid. So meconium-stained fluid could be associated with fetal distress. Blood amniotic fluid may indicate placental abruption or fetal trauma. And then an unpleasant odor of the fluid could indicate infection as well. All right, so vacuum extraction. So, vacuum extraction is when a suction device is used to help assist in labor. So, that suction device should not be kept in place any longer than 25 minutes. After vacuum extraction is utilized, you want to monitor for the development of a cephalohematoma and then caput coccideum, I can never pronounce that word. Monitor for caput coccideum also, and know that that is normal. It usually resolves on its own in a few days. And we talk about that in our care of the newborn section, but know that your cephalohematoma is bleeding beneath the skull. It does not cross the suture line, whereas your caput coccideum is swelling in the tissues above the scalp. It does cross the suture line. So a C-section, a cesarean delivery, is delivery of the fetus through an abdominal incision. So post-op, it's very important to monitor for any signs and symptoms of infection. So dysuria may indicate infection. A tender uterus and foul-smelling lochia may indicate endometriosis. And then also recognize that a productive cough or chills may indicate pneumonia. All right, premature rupture of the membranes. So this refers to spontaneous rupture of the amniotic membranes before the onset of labor. So when rupture occurs before term and then the childbirth is delayed, infection becomes a great risk. So you want to avoid any vaginal exams due to risk for infection. And then you also want to monitor the fetal heart rate because tachycardia in the fetus could indicate maternal infection as well. The assessment, you're going to have the presence of fluid pooling in the vaginal vault, and then a nitrate test on that fluid is going to be positive. All right, a prolapsed umbilical cord. So with a prolapsed umbilical cord, the umbilical cord is compressed, which compromises fetal circulation. So the mother is going to feel like something is coming through the vagina. The umbilical cord may even be visible or palpable, and you will have variable decelerations on the fetal heart rate monitor or bradycardia after rupture of the membranes. In the case of a prolapsed umbilical cord, you are going to prepare for immediate birth. So you want to elevate the fetal presenting part that is lying on the cord by applying just a single finger pressure with a gloved hand to relieve that cord pressure. You never want to attempt to push the cord back into the uterus. You're going to administer oxygen to the mother via face mask. You're going to place the mother in an extreme Trendelenburg positioning just to help try to get some of that pressure off of the umbilical cord. And then if the umbilical cord is protruding, you're going to wrap the cord loosely in a warm, sterile towel. All right, supine hypotension or vena cava syndrome. So this occurs when the venous return to the heart is impaired by the weight of the uterus on the vena cava. So it results in partial occlusion of the vena cava and aorta, which results in reduced cardiac output, and reduced blood pressure. So you want to always position the patient on their side to shift the weight off of the vena cava. So in order to prevent supine hypotension, you want to avoid the supine position. So you're going to position the patient by placing a pillow or a wedge under the patient's hip to displace the uterus off of the vena cava. All right, amniotic fluid embolism. So this is the escape of amniotic fluid into the maternal circulation. So the debris containing amniotic fluid deposits into the pulmonary arterioles, and this is usually fatal to the mother. So this is an emergency. You're going to want to prepare for intubation and mechanical ventilation. So the mother is going to experience cyanosis and an abrupt onset of respiratory distress and chest pain.